Hello, I'm Eddy Barasch from St. Francis Hospital, Roslyn, New York, and this is the second portion of our lecture, The Many Faces of Aortic Stenosis. I'd like to remind you the last slide of the prior presentation with the hemodynamic classification of severe aortic stenosis based on mean pressure gradient 40 and stroke volume index of 35 milliliter per meter square, where patients with normal flow can have low or high gradients, and as patients with low flow can have, again, low gradients or high gradients less than more than 40 millimeter mercury, respectively. These four categories may have some distinctive characteristics, which I hope to show you in the following slides. But before it, I like to remind you the two main reasons of discrepancies in the aortic valve area and pressure gradients as reported by catheterization and Doppler echocardiography. The first one showing us the anatomic valve area, peak-to-peak gradient, and the second one, the functional valve area, which is the instantaneous velocity across the aortic valve transformed in pressure gradients as measured by Doppler echocardiography. This cartoon illustrates sections with the left, longitudinal sections with the left ventricle, left ventricular outflow tract, anatomic aortic valve area, effective orifice area, and ascending aorta. And the diagram shows the respective behavior of the pressure gradients. So when the blood flow contracts to pass through the stenotic orifice or the anatomic aortic valve area, a portion of the potential energy of the blood, i.e. pressure, is converted into kinetic energy, i.e. velocity, resulting in a pressure drop and acceleration of flow. Downstream of the vena contracta, or the effective orifice area, a large part of the kinetic energy is dissipated as heat because of the turbulent flow. The remaining portion of the kinetic energy that is reconverted back to potential energy is called pressure recovery, this one here. The global hemodynamic load imposed on the left ventricle during ejection, it's a summation of the valvular load and arterial load. And it's expressed as a global afterload of valvular arterial impedance, which is a summation of systolic blood pressure with mean pressure gradient divided by stroke volume index, a value of equal or in excess of 4.5 millimeter mercury per milliliter a meter square. It's considered to bring poor prognosis in patients with severe aortic stenosis. And if you wish, it's the price in millimeter mercury of moving 1 milliliter or ejecting 1 milliliter of blood from the left ventricle during systole. So pressure recovery and how the gradients are measured explain why at many times aortic valve area reported by echocardiography is lower than that reported by catheterization. The first category is the classic aortic stenosis, those that we knew for many, many years. Normal flow, high gradients, meaning flow 35, stroke volume index 35 or more milliliter per meter square, and high gradients, meaning 40 or more than 40 millimeter mercury. This category comprises most of the patients of aortic stenosis. The diagnosis is consistent with the guidelines criteria. In asymptomatic patients, there is a role of exercise treadmill, which comes out positive in about 30% of these patients. An increase in mean gradient, more than 20 millimeter mercury at peak stress, as increase in abnormal brain natriuretic peptide serum level bring poor prognosis, so this patient should be sent to aortic valve replacement sooner than later. Usually the global afterload is equal or less than 5 millimeter mercury per milliliter meter square. and survival at 2 years is in excess of 80%. So this is a classic severe aortic stenosis with normal ejection fraction. The second category with normal flow is those patients who have low gradient. So normal flow with low gradients, less than 40 millimeter mercury. And meta-analysis done a few years ago in more than 7,500 patients shows a prevalence in general about 30%, but in some papers was reported up to 50%. This is a heterogeneous group where errors in measurements should be sought and corrected. Many of these patients have a small body size, and one of the reasons for this diagnosis resides in the inconsistency in grading in the guidelines, as I showed you in the first lecture, where actually a valve area of 1 centimeter square corresponds with 27 millimeter pressure, mercury pressure gradients and arrhythmias. About 50% of these patients have hemodynamic severe AS, meaning that half of them do not have. The global longitudinal strain is in general preserved. The BNP serum level is less than in classic aortic stenosis. And the prior papers in a few years ago reported a similar outcome to classic severe aortic stenosis and better than low flow, low gradient. But more recently has been shown that this group of patients is normal flow, low gradients is quite similar with those with moderate aortic stenosis in the terms of prognosis. So this is from the meta-analysis of Dr. Dayan and his colleagues showing the odd ratios of mortality and comparing normal flow low gradient with classic aortic stenosis. So basically they did not find a difference. So the odd ratio, it crosses 1. However, the protective effect of aortic valve replacement was the highest among patients who had classic aortic stenosis and similar in other categories studied. A paper from University of Amiens in France shows that patients who have high gradient aortic stenosis have a higher mortality than those who have moderate aortic stenosis, depicted in blue, low gradient normal flow aortic stenosis in orange, or low flow, low gradient in green. So again, patients who have low gradient normal flow in orange here have a similar outcome with those who have moderate aortic stenosis. And finally, even more recent studies from the same university show again no difference between moderate aortic stenosis and normal flow low gradient. So in these patients with normal flow low gradients, to establish with certainty the presence of severe aortic stenosis, other methods should be applied, like total global calcium load, or valvular calcium score by CT, low dose dovitamin echocardiography, projected aortic valve area, or flow rate, as I will show you in the following slides. The third category is low flow, high gradients, seen in about 20% of patients, is driven by excessive body weight, about 80% of them, and they have the highest BNP level as reported in a study by Dr. Patricio Lancelotti a few years ago. The global longitudinal strain is less than normal flow low gradient, and they have a higher mortality than normal flow high gradient, meaning that have a higher mortality than classic aortic stenosis. So whenever we see patients who have a low flow, high gradient, these patients are the highest risk of patients with aortic stenosis, and probably they should be sent to aortic valve replacement sooner than patients belonging to others three categories. This is a study in 983 patients with normal flow, with low flow, high gradients. And the low flow was considered not, the threshold was considered 30 and not less than 30, not less than 35 millimeter per mercury, millimeter per meter square. So we see here a higher mortality, cumulative mortality in those patients with less than 30 compared with those with 30 milliliter per meter square, and the hazard ratio showing us that these patients have double mortalities than those who have a stroke volume index in excess of 30 milliliter per meter square. The fourth category, it's a low flow, low gradient, or paradoxically aortic stenosis, as coined by Dr. P. Barasch and Dumenil from Quebec University in Canada. Less than 10% are asymptomatic. The prevalence in symptomatic patients can reach 35%, but usually it's in the range of 25-30%. It's a heterogeneous group. Many patients have a history of heart failure and atrial fibrillation. This is a diagnosis of exclusion. We have to rule out pseudostenosis with low-dose dobutamine echocardiography or other methods. Potential confounders should be taken into consideration, like significant mitral or tricuspid regurgitation. And the diagnosis should be validated if it doesn't fit the clinical manifestation by other methods like calcium score, low-dose dobutamine, projected aortic valve area. Apparently, they are doing better with TAVI than with surgical aortic valve replacement. If asymptomatic, one should treat them conservatively. And the dimensionless index, meaning the ratio of LVOT TVI by aortic TVI less than 0.25 brings a poor prognosis, as shown in a recent paper from a general hospital, and these patients should be sent to aortic valve replacement sooner than later. So DOI value in this group of patients should be taken into consideration as a risk stratification variable. The first report, interesting enough, was almost 17 years ago in 150 patients who, in whom 12 of them had a peak-to-peak gradient less than 50 millimeter, but a normal ejection, normal systolic function. At 2.5 years follow-up, half of them died before aortic valve replacement and half had developed congestive heart failure. This slide is from the original paper, Dr. Hakita and his colleagues, showing the main difference between normal flow and paradoxical low flow, where these patients had a lower valve area, a higher global afterload, and smaller hearts. Our group reported a few months afterwards in 2008, a cohort of patients divided by mean gradient less or more than 30 millimeter mercury. So those patients with less than 30 millimeter mercury had lower stroke volume index and higher systemic vascular resistance than the other group. Overall survival in patients who have paradoxical low flow is poorer than those with normal flow. And in addition, with DOI that I showed you before, less than 0.25, global afterload more than 5.5 is associated with increased mortality in this group of patients. We reproduce the same results when we divided the patients by a threshold of mean gradient of 30 millimeter mercury, such as those patients who have mean pressure gradient less than 30 millimeter mercury had a much poorer prognosis. This is survival probability at 5 years was about 75% compared with almost 88% in those who have more than 30 millimeter mercury. Mayo Clinic reported similar results. Patients with low flow, low gradient have poorer prognosis than other categories. And in multivariable predictor of all-cause mortality, the risk, relative risk was 3.2 and low flow, low gradient without AVR, and compare with 2.8 in classic aortic stenosis, normal flow, high gradient without AVR, so medically treated. Again, patients with low flow gradient compared with normal flow, low gradient or moderate aortic stenosis have a poorer prognosis. Finally, a recent paper showed that aortic valve area is not associated with a prognosis if the flow rate, which is measured as a ratio between stroke volume and ejection time. So a flow rate less than 210 milliliter per second brings a neutral prognosis for aortic valve area, where a flow rate in excess of 210 milliliter per second is associated with severe aortic stenosis, and the aortic valve area has prognostic value. We hope to see you in the last part of this presentation soon. Thank you very much.